Hello, good morning, everyone. Nice to have you all today. We have ECG session, and my name is Ilham Babakir, one of the pediatrics trainee here in the UK, and an academic member of BSAPCH. And we are running this ECG session, which is, I believe all of you know the importance of ECG, as you would be encountered with a lot of situations. You would be the first one to read the ECG and to have a quick look and decision upon that. And even it could be non-cardiac situations like you see the patients with anorexia nervosa and patients with hyperkalemia and a lot of other pediatric condition apart from cardiac, which is the main bulk for ECG conditions to be seen, which is an emergency like arrhythmias. So we are here today to sort out ECG and for everyone aiming to be able to read the ECG and to have the basics of this ECG today. So we'll start this session with quiz, and it's like a poll. It's like 5 minutes, 1 minute for each, and feel free to just press. It would be anonymized. No one would know who did this answer, and it just helps us to know the pre-knowledge before this session. And we got two esteemed speakers today. Dr. Abdah Hrfi, who would run the session of how to read the ECG today. Welcome all, and hopefully you enjoyed this session, and it would be very, very strong addition to your portfolio as well if you're planning like grid or spin, or you are doing like cardiology planning to go forward in your career. So take this opportunity to take your boxes and to have more credit on. So we would start with the first poll, please. So we'll get like 11, 4, 1. Can we press the button for polls, please? We are 54 at the moment, so I need more people to participate in this poll. It's just like quick assessment to know where we are. Increasing number. Got 16. We need more. Come on, guys. Um, Mohammed, it seems like we have some people who can't see the pool. That's why we got this low number. So can we try? Mohammed, are you here? I'm sorry, it seems we got like technical issue with this poll, so we'll try it later. We're gonna carry on the lecture, and I would like to introduce our first esteemed speaker, Dr. Abdah Hrfi, and he had extensive cardiology experience overseas, and he got international level of this. He worked in Saudi Arabia as assistant consultant after having his Saudi fellowship in cardiology and a lot of membership like European Society of Cardiology and the British Congenital Cardiac Association. And he's currently working as a clinical fellow in pediatric in Leeds of cardiology, and he enjoys teaching as regional teaching and international education sessions. We are so happy to have you today, Dr. Harfi. So all floor is yours. Can you proceed, please? Thank you.
Thank you very much for this nice introduction. I will go through my presentation. Just I'll share my presentation. Can you see my slides now?
Yes.
Fine. Yeah, I will start with my presentations, how to read the ECG. Initially, I will start with what the normal pathway for electricity to travel through the heart. Actually, the impulses of the heart started from sinus node, which is that structure located at the junction between the SVC and right atrium, which is epicardial structure, and give the sinus node give impulse to activate right atrium and left atrium, then to go to AV node. Then from AV node, the impulse go through the his bundle, then the left bundle, right bundle, then the Purkinje fibers to activate the ventricles. A bit more details. The SA node starts the impulse to activate right atrium first, then left atrium by the Bachmann bundle, then go to AV node, which is located at the floor of the right atrium, just medial to the tricuspid annulus, which is give impulse to bundle of Hess, then left bundle of right bundle, and then to activate ventricles. When we lose the power of the heart, that meaning we know that the impulse started from sinus node, which is with the rate of 60 to 100 beat per minute. If sinus node damaged, the atrial focus or atrial foci will take over with inherent rate of 60 to 80 beat per minute. And if atrial foci doesn't work, the junctional foci will take over with an inherent rate of 40 to 60 beats per minute. If an emergency junctional foci doesn't work, then the ventricle foci will take over with rate of 20 to 40 beats per minute. Then the lower the level in the heart where the foci is located that is doing the pacing, the lower is the inherent rate, which is produced by that area. What the meaning foci? Foci is a potential pacemaker of cell that is capable of pacing in emergency situation. Any area of the atrium or ventricle can be foci to give the start impulse. What's the mechanism of the machine? What the electrical basis of the machine? Electrical impulses are present on the skin surface at a very low voltage. The ECG machine picks up these impulses and amplifies them. Electrical activity is sensed by electrodes. Slits are placed on the skin surface to pick up these impulses and give us a picture of how they are traveling in the form of electrocardiogram. This is printed ECG paper and is called a rhythm strip or an ECG strip. What about lead placement? I know you know that lead placement, but however, just I will remind you, we have 3 limb leads, which is right arm, left foot, and right foot, which is neutral. And we have 6 precordial lead, or we call it chest leads, V1 to V6. V1 located in the 4th intercostal space, right sternal edge. V2 located on 4th intercostal space, left sternal edge. V3 midway between V2 and V4. V4 in 5th intercostal space, mid-clavicular line. V5 anterior axillary line is a straight line with V4, and V6 mid-axillary line in a straight line with V4, V5. V1, V2, we call it septal leads, V3, V4 anterior lead, and V4, V5, V6 lateral leads. However, we have here just 9 leads. Why we call it 12 lead ECG? Actually, there is what we call it like virtual lead between right atrium and, right arm and left leg. We call it lead 2. Between right arm and left arm, we call it lead 1. And between left arm and left leg, we call it lead 3. Now we have 12 lead ECG. We call it bipolar limb leads. As you know, stages of the heartbeat, P wave, QRS, and T wave. P wave represents atrial contraction, atrial depolarization. QRS represents ventricles contraction or depolarization, and T wave represents ventricle repolarization. Then what is the atrial repolarization? It happens just during the QRS ventricle repolarization, which is hiding within QRS. P wave, QRS, T wave make up one complete cardiac cycle. How we measure ECG paper? As the paper prints out from machine, we are measuring time. We are measuring duration. Okay, measuring time in seconds. While in the vertical line, it is amplitude, power of signal. How we measure it by millivolts. Then vertical line amplitude, this amplitude of wave, and horizontal line is a duration measured in seconds with the speed of paper. We know that ECG is divided on the large square and small square. Each small square 1 millimeter by 1 millimeter block. 1 millimeter represent in the horizontal lines time, which is 40 milliseconds, while 1 millimeters in vertical amplitude is equal to 0.1 millivolt amplitude. Then one large cube is equal to 5 millimeter with 5 millimeter box represents 0.2 second, which is 200 milliseconds in the time, while amplitude represents 0.5 millivolts amplitude, that's 5 small square. Technical aspects. As we see that here, the speed of paper was the standard speed of paper 25 millimeters per second, that means 1 centimeters per second, while 2.5 centimeter per second. While amplitude, it's just 10 millimeters, which is 1 millivolt, okay? Then the voltage standard calibration, we call it full standard. The voltage should be 2 large square or 10 millimeters. It's equal 1 millivolt. We call it full standard. While voltage 5 millimeters, that means only 1 large square, we call it half standard, half waves. While in speed, the standard speed of ECG machine is 25 millimeters per second. We call it also full standard or standard speed. When the speed of machine is 50 millimeters per second, that meaning the heart rate will be slow, right? That we call it double standard. Heart rate will be slow, half heart rate, and all the duration will be double. When we calculated heart rate with speed 50 millimeters per second, we have to multiply heart rate by 2, and all duration we have divided on 2. That's why we always used only standard speed in machine, 25 millimeters per second. As I mentioned, that standard calibration is 10 millimeters, 10 small boxes equal to 1 millivolt. On occasions, particularly when the waveform are small, sometimes we need to double the standards. Just we use 20 millimeters equal to 1 millivolt when the waveforms are very large. Half standards may be used 5 millimeters equal to 1 millivolt as well. Paper speed and voltage are usually printed on the bottom of the ECG here. Then when the wave is small, we double standards. When the wave is large, we use just half standard. What the indication of ECG? Indication of ECG: chest pain, syncope, palpitation, cyanotic episode spills, seizures or funny turns, drug ingestion, abnormal cardiac examination, electrolyte abnormalities, family history of sudden death of life-threatening events. How to read ECG now? We have to put some plan or systematic plan to read ECG to be standardized method. Even during exam, you have to be standardized. You have to get approach steps by step, okay? The first step before we start to read ECG, we have to mention that how many leads, the ECG, how many leads. Sometimes we can use 6 leads, sometimes we use 8 leads, sometimes we use 3 leads. We have to describe what we see. 12 leads, number of leads, we have to describe also what the long strip of the ECG. Like this ECG here, 12 lead ECG, I will tell 12 lead ECG with long strip lead 2. And you know that all what there is down this the speed, machine speeds, and how the power of the machine as well. For example, this one, 12 lead ECG with V1, lead 2, V5, long strip. 12 lead ECG with a long strip V1, lead 2, V5. I have to describe before I will start to read ECG. What about next step? I have to mention, I have to be careful that the ECG printed by standard calibration. Standard calibration should be 10 millimeters, just 2 large square in amplitude with a paper speed of 25 millimeters per second. Like this, 25 millimeters per second and 10 millimeters square in amplitude. For example, the PICU team called me for 2 months old baby. He told me has SVT and given adenosine not respond. Please check this ECG. What do you think? Anyone can comment? Can you write in chat? Yes, you are right. If you just recognize that the speed only 5 millimeters per second, that meaning the heart rate multiplied by 5 times. Heart rate multiplied by five times. Then when I just adjust the speed of paper to 25 millimeters per second, this is the ECG of patient. Just the 2-month-old has 170, 150 beat per minute is normal. It's not SVT. Then be careful about standardized of the paper. Next, step number 3, we have to comment on heart rate. Is it normal heart rate? Is it bradycardia or tachycardia? How to calculate heart rate? Really, there is many ways how to collect heart rates, but the most practical way is this one. Either just to divide 300 over the number of large boxes between 2 RR, or to divide 1,500 over the number of small boxes. Where did these numbers come from? 300 large box. Recall above the 300 large box equal to 1 minute, because we know that each large box equal to 200 milliseconds. 300 large box multiplied by 200 milliseconds equal to 60 seconds, that meaning 1 minute. When we calculate beats and large, and when we calculate, then we'll divide it 300, which is large books, on the how many large books between 2 RR, that meaning I can know how many beats this patient has. This one in regular beats, that meaning regular RR equal RR. While if the patient has irregular rhythm, how to calculate the heart rate? It's easy also as well. We'll calculate number of RR interval in 30 large books. 30 large books equal to 6 seconds. Then we calculate how many beats in 6 seconds, then multiply by 10. Same things for the small books. If I divide it myself, I use this way to calculate heart rate. I will divide it 1,500 on the how many small books between RR. For example, here, I have 10 small books, 1,500 divided by 10 equal to 150. This patient has 150 beat per minute. This is a very practical way, and this is the easiest way. I will go to number 4. I have to mention that, is that rhythm regular or not regular? In general, when I tell that patient has regular rhythm, only one word of regular rhythm, that meaning I meant that this patient has equal RR interval. Equal RR interval. This patient has regular rhythm. If patient has irregular RR rhythm, that meaning patient has unequal RR. Sometimes you heard about what we call it regular, irregular rhythm. First, regular indicate that the amplitude of waves, if regular, that meaning equal amplitude of wave. The second irregular is indicate that unequal or equal RR interval. And this rhythm, we call it regular, irregular, sinus arrhythmia. If I hear just only one word, regular rhythm, that meaning indicate RR interval. While if I hear that regular, irregular, that meaning the first regular, which is amplitude of waves, the second irregular indicate the RR interval. Like this ECG, what do you think here? This we call it irregular rhythm. Irregular rhythm, this is disease, this patient has problem. The first irregular is irregular in amplitude. The second irregular, the unequal RR interval. Then this we see in this disease, the excited fibrillation. Maybe later on in my next presentation, I will explain more about this. Then the fifth step, I have to mention that is that rhythm sinus or not sinus? What the conditions of sinus? If I have each QRS preceded by P wave and each P wave followed by QRS and should be P wave positive in AVF and negative in AVR. This is the definition of sinus. When I tell that this rhythm is sinus, supposed to be each QRS preceded by P wave and each P wave followed by QRS and supposed to be positive P wave in AVF and negative in AVRY. As you know that sinus node starts at the impulse and give the impulse down to the left side of patient. The inferior lead, which is lead 2, lead 3, AVF, this we call it inferior lead, or the lead down. If the impulse or signal goes toward the leads, give positive inflect. While if the impulse going against the leads, that meaning give negative inflect, okay, or deflect. Lead 2, positive deflect, because also the impulse coming to the lead, to lead 1, okay? This one, what we call it sinus, that meaning in AVR, P wave will be negative, while in inferior leads should be positive to tell this one sinus, that meaning coming from sinus node. Then, as you see here, normal ECG, P wave in lead 1 positive, in AVF positive, and also lead 2, lead 3 also positive, while in AVR negative. The B wave are negative in AVR. Okay, because the AVR that right lead. It is sinus rhythm. What do you think about this one? It is also sinus rhythm. See the lead 1 P wave positive, inferior lead 2, lead 3, AVF, inferior lead, we call it positive, AVR, P wave negative. And each P wave followed by QRS, and each QRS preceded by P wave. This is what we call it sinus rhythm. Is this rhythm sinus? This is irregular rhythm. Is this rhythm sinus? Yes, it is sinus. That's why we call it sinus arrhythmia, which is benign in the children. Sinus arrhythmia. Why? Why sinus? Because P wave positive in inferior lead, which is lead 2, lead 3, AVF, and it is negative in the right lead, which is AVR. That meaning sinus rhythm. This patient has sinus rhythm, but irregular rhythm. What do you think about this one? Anyone can comment.
It's positive in AVR, isn't it? The P wave, so it's not sinus.
Yes, it's not sinus. There is one question in the chat. He asked me why P wave negative in AVR, not in this ECG, in ECG. Here, because AVR in the right side, right? AVR here in the right arm, while sinus node, the impulse going against the right leads, then will give negative deflect. Again, this one not sinus rhythm. Why? Lead 1 positive, but C in AVF negative. That meaning the impulse of P wave going away from AVF, going from down to up. AVR positive P wave, right? If AVR positive P wave, that meaning the impulse going toward right side of the patient's right arm. That meaning patient have what we call it low atrial rhythm. That meaning the impulse will be here, somewhere in the right atrium, and give impulse like this. From down to up, toward AVR and against inferior lead. That's why we call it low atrial rhythm, not sinus. Then after we determine that ECG sinus or not, we'll go to calculate axis of the heart. We have to comment of the axis of the heart. Normal heart axis, as you see here, from up, going down to the left of the patient. This is the axis of the heart. Normal axis of the heart between -30 to 110. This is the normal axis of the heart. When we calculate axis of the heart, is it normal or right axis deviation or left axis deviation? We take that two perpendicular leads, which is lead 1 and AVF. These two perpendicular leads. This part is positive and this part is negative. When this part is positive, this part is positive and this part is negative. And when we tell that axis of the heart, that meaning the QRS of the ECG, the ventricular axis. We mean ventricular axis, QRS, the ventricular activation, ventricles dolarization, okay? As you see here, 0 degree, here minus, because all this measurement minus, while all this one positive. -30, -90, -150, 180. If the axis comes between this measurement, -30 to +90 or 120, that meaning normal heart axis. If less than -30, that meaning left axis deviation. While if more than 120, we'll call it right axis deviation. If the axis in this quarter here fall in this quarter here, we call it extreme axis deviation or northwest axis. For this example, as you see that here, the axis of the heart in the AVF, as you see here, will be positive, and while in lead 1 will be negative, and in lead 2 will be positive. Lead 2 and lead 3 down will be positive. That meaning R wave more than S wave. If the axis going up, that meaning in lead 1 will be positive, R wave more than S, while in lead 2, lead 3, inferior lead will be negative, S wave. Why I just put this image here, just to show you that at a newborn, when the baby born, the RV right ventricle will be dominant. That meaning that the ECG at newborn will be right axis deviation normally, not left axis deviation. Why? Because 60% of cardiac output during the fetus life depended on the right ventricle. Right ventricle gives blood through the PDA to all the body. Then at birth, the baby has the at birth has right axis deviations. At 2 to 5 years will be normal axis. As you see, really this is nightmare here, just to remember that which one positive, which one negative, and which one's axis deviation. I have very nice trick here. I will let you know. Just put your ECG in front of you. As you see here, a lead 1 in your left side, right? And AVF in your right side. When you put that ECG in front of you, lead 1 represent your left hand, AVF represent your right hand. Yes. Then, if your right hand up, that meaning right hand positive, and your left hand down, that meaning you have right axis deviation. Fine. If your right hand up, that meaning AVF positive, and your left hand down, that meaning you have right axis deviation. If you have right arm up and left arm up, that meaning normal axis deviation. If you have two hands down, that meaning lead 1 negative and AVF negative, that meaning northwest or extreme axis of the heart. Is that clear? Really very simple and very useful is a practical point. Just put ECG in your front, lead 1 represent your left hand, AVF represent your right hand. Like this patient here, he has normal axis deviation because lead 1, which is right hand up and left hand up and right hand up. Okay. What do you think about this one?
I think they want the previous slide. Someone in the chat asked for the previous. Yeah.
What does chat? Just let me check here. Can we see the previous slide again quickly? This one or previous? This one you mean?
Yeah, this one. Yeah.
Okay.
Yeah.
When you have positive, that meaning a normal axis deviation, and lead 1 positive, and then in lead ABF negative, possible left axis deviation, negative lead 1 positive in ABF, that meaning right axis deviation, negative in lead 1 and negative in ABF, that meaning extreme axis or northwest axis. I explained the trick. I think you got my trick, right? What do you think about this ECG?
Sorry, I'm not sure if it's clear for them because few people ask if you could just kindly explain again the right and axis.
Okay, fine. Just put ECG in front of you, like this ECG. Lead 1 will be in your left hand, right? And AVF in your right hand. If your left hand, if QRS positive in lead 1, that means left hand up. Okay, left hand up, that meaning left axis deviation. If AVF QRS positive here, while in lead 1 negative, AVF represent right hand, your right hand. If QRS positive in AVF, that meaning right hand up. While negative in lead 1, that meaning left hand down, that meaning patient has right axis deviation. Lead 1 positive, my left hand up, left axis deviation. AVF represent my right hand. If AVF QRS positive, that meaning right axis deviation. If my hand up, that meaning lead one positive QRS and AVF positive QRS is normal axis deviation. If my 2 hands down, that meaning lead 1 negative and AVF negative, that meaning northwest or extreme axis deviation. Is that clear? This is a trick just to give a very quick answer about axis of the heart. Let us apply this one here to be clear, to be more clear. Okay, this is ECG in front of me. Lead 1 is my left hand. Lead 1 down, QRS negative, right? R and S wave more than R wave, that meaning S wave negative, that meaning all the QRS and the lead 1 negative. Lead 1, that means represent my left hand down. AVF represent my right hand, QRS positive. R positive more than S wave negative, that meaning in general positive. When my right hand up and left hand down, that meaning right axis deviation. If left hand up and right hand down, that meaning left axis deviation. Is that clear here? Now.
Yeah, I think they guess the right answer in the chat box.
Yeah.
Yeah, thank you.
Right axis deviation. Again, this one here, very fast, give me. Anyone can know that one, what was the axis deviation? Yes, left axis deviation. Why? Because left hand up, my right hand down. Left axis deviation. What about this? Left hand down and my right hand down, both down. That means patient has northwest axis or extreme axis deviation. This is VTAC. Then I will go to next step to P wave. The P wave, actually the P wave represents the atrial contraction, right? The atrial contraction, the P wave is actually, there is 2 components of P wave. The first one, right atrium, because the SE nodes start to activate right atrium. Then the last one or second one, left atrium. When we have normal value of P wave, the width of P wave just less than 3 millimeters, while the height of P wave less than 2.5 millimeters. Best seen P wave, best seen in lead 2 and V1. Okay. Then just remember the first part of P wave represent right atrium. The last part of P wave represent left atrium. In atrial hypertrophy, what's the criteria of right atrial hypertrophy? Right atrial hypertrophy, that meaning the first part going up, tall P wave, more than 3 millimeters in any lead. We call it P pulmonale. Why we call P pulmonale? That meaning there is increased either pulmonary hypertension or pulmonary stenosis, that meaning increased pressure in the right atrium, which make it high. That we call it P pulmonale. P wave, more than 3 millimeters. What the criteria of left atrial hypertrophy? Left atrial hypertrophy, we know that the second part of the P wave represent left atrium. If we have left atrium hypertrophy, that meaning prolongation of the P wave duration. Prolongation, not up, going prolongation. You will see that broad P wave, sometimes notched P wave. If you go to anatomical right atrium and left atrium, you will see that right atrium looking like vertical structure, while left atrium looking like horizontal structure. That meaning when you have that right atrial hypertrophy, the P wave will go up tall, while when you have that left atrial hypertrophy, the P wave will be broad. Combined atrial hypertrophy, that meaning both amplitude and duration of the P wave will be increased. Again, that's one normal. You will see in V1 biphasic P wave and lead to positive. When you have right atrium enlargement, we'll see P wave, tall P wave. Left atrial enlargement, you will see that second part increased with broad or notched P wave. When you see right atrium and left atrium enlargement, you will see that this shape both together. Then after I just determine P wave shape, I will go to PR interval to comment about PR interval. PR interval, it's equal to distance from sinus node to EP node, including EP delay. Normal value, it is 0.1 to 0.2 seconds or 100 to 200 milliseconds. This one also different according to the age of the patient. First degree of a block, what we'll see, prolongation of PR, okay, the PR interval. P wave should be before HQRS. The PR interval more than 200 milliseconds or more than 0.2 seconds. See here, prolonged PR. Prolonged PR, okay? The PR is static or constant, but prolonged PR. You will see the rhythm is the regular rhythm. RR equal, right? PP equal. This is first degree AV block. Prolongation of PR, as you see here, prolongation of PR more than 200 milliseconds. What about Mobitz 1? In second degree block, Mobitz 1, Wingbach. The PR interval progressively increased until the dropped QRS, meaning BR normal, then will be longer, then next beat more longer, then P wave without QRS. We call it dropped QRS or blocked P wave. Okay, this pattern is repeated. This pattern increased, dropped QRS, increased, dropped QRS. This is what we call it Wingbach. Okay, or wait, Mobitz 1. What about Mobitz 2? In Mobitz 2, there is no pattern, but you will see that this PR could be normal, but you see that blocked P wave, that dropped QRS. P QRS, then P without QRS, dropped QRS. But PR would be constant and normal, okay? Less than 120 QRS as well. PR interval, normal. P more than R wave. Then in Mobitz 2, you will see PR constant and normal, but P wave, the second P wave dropped. This we call it sometimes 2 to 1 block in advanced, okay? Second degree of block, Mobitz 2, it's blocked P wave with normal PR interval and constant, there's no progression. While third degree AV block, what we call complete AV block, There is condition for that. What the conditions? The first things you have to have AV dissociation. AV dissociation, that meaning P wave not related to QRS. The P wave giving impulse, P wave, P wave, P wave, regarded the QRS. See here, P wave, P wave, P wave here, regarded the QRS, working separately, the atrium working separately to the ventricle. AV dissociation. You will see bradycardia, and you will see not every QRS preceded by P wave. Equal PP interval. If you take PP interval will be equal because sinus nodes giving impulse in regular type, right? In regular pattern. P wave equal PP interval and also equal RR interval because the ventricle give R wave in equal pattern as well. But we have AV dissociation, that meaning P wave not related to QRS. You can see P wave everywhere. And the other condition that P waves should be more than V wave. Okay, when you count P wave, see here how many P wave? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 P wave here, while we have only 3 QRS. This we call it complete AV block. That meaning AV node not working. Any impulse coming from SA node not going to ventricle, just blocked. That meaning atrium will give P wave, constant P wave, and then the ventricle will give the QRS, okay? Junctional area, just below the AV node, give me this rate. And we know that the ventricle and junctional rate less than sinus node rate, right? As we mentioned at the beginning. This is what we call it complete AV block. AV dissociation. Just summary, first degree AV block, PR interval constant, same, regular, but prolonged. And second degree AV block, Wing-Bach, different PR interval. PR interval gets longer until first QRS drops. Second degree moves to the PR interval also same, constant PR interval the same when we can measure it. Third degree AV block, the PR interval will be different. Whenever you see that PR interval different, that meaning patient either has first degree AV block or third degree AV block. When you have dissociation, that meaning patient had third degree AV block, while only prolongation of PR with constant PR, that meaning first degree AV block. Then after I just determined PR interval, I have to comment on QRS. Is the QRS narrow or wide? Why the QRS more than 90 milliseconds? At pediatric age, usually the normal QRS supposed to be until 80, sometimes 90. More than 90 milliseconds, that meaning more than 3 small Q square, we call it wide QRS. While narrow QRS just less than one square. Normal QRS between 70 to 90 milliseconds, that meaning 2 small or 3 small QRS. We know etiology of wide QRS complex could be non-specific interventricular conduction delay, bundle branch block, ventricular ectopic beat, ventricular excitation or excitation, or Parkinson white, left ventricular hypertrophy, hyperkalemia, hypermagnesemia, pacemaker-generated beat, hypothermia, drug toxicity. Any one of these can make wide complex. Let us come to bundle branch block. A lot of questions about bundle branch block, what the mechanism of that block. Bundle branch block could be acquired and could be congenital as well. Normal P wave, you know that PQRST. In bundle branch block, we see that wide QRS more than 3 small square or more than 120 milliseconds or 90 milliseconds in the pediatric. Let us explain what will happen here. This is the heart here, it's right ventricle, left ventricle, and this is the chest lead or precordial lead. what we see normal here, just to let you know that the interventricular septum depolarization will come from left side to right side. That being the impulse coming from sinus node to AB node, then to left left bundle brush block, to left bundle, and then the interventricular septum's depolarization coming from left to right side, then the left ventricle depolarized, then the right ventricle depolarized. This is a normal. That meaning in V1, what we'll see normal, in V1, the interventricular septum will come from left to right, that meaning the impulse going toward V1, that meaning V1 will be positive. While V6, which is far from the impulse direction, will be negative. Then after depolarization of interventricular septum, the dominant ventricle, which is left ventricle, will start to depolarize. That meaning the depolarized will come from right to left. Then in V6, in V1, the direction of depolarization of left ventricle will be against V1, that will be negative deflection, while in V6 will be positive because all the depolarization coming toward the V6 will give me positive. This is a normal. In V1, we'll see that RS wave. In V6, we'll see the Q and R wave, okay? What happened in the bundle branch block? A left bundle branch block, that meaning there is no impulse coming from left to right. The impulse from AB node to his node to right bundle, and from right bundle to the left side, that meaning interventricular septum will start depolarized from right to left side because this bundle is blocked. What will happen here in V1? V1, then we'll have the impulse will be against the V1, that meaning will be negative in V1, right? While in V6, at the same time, will be positive because the impulse toward V6 will be positive. Then the left ventricle embolize start also be positive in V6, while negative in the V1. We'll see notch here because also there is late, all the ventricle, left ventricle is dominant, left ventricle will depolarize again. Late depolarization of left ventricle. That's why we see the notch here in V6. Then W shape in V1 and would call it M shape in V6 in bundle brush block, in left bundle brush block. While in right bundle brush block, this right bundle, there is no right bundle here. All the depolarization will come, the interventricular septum as normal from left to right. In V1 will be positive. In V6 will be negative because against V6. Then the left ventricle start depolarized, will be negative in V1 and positive in V6. Give me M shape in V1, right bundle, while give me W shape in the V6. Slurred S wave, we call it. Then in left bundle, we have W on V1 and M shape in V6, left bundle, L. While in right bundle, we have M in V1, W in V6, the right bundle. Just we collected that in your William here, William W, L left, M in V6, while Maro, we call it in the right bundle, M in V1, W in V6, right bundle, William Maro shape, just to remember this one. Here we have M shape, V1, W in the V6, that meaning patient has right bundle brush block. While W in V1, M in V6, this patient has left bundle brush block. I have a trick for this one also. It's all the tricks actually in my experience here. I have a trick here. Just look at V1. No need to look at V6. No need to look at anything. Just look at V1 and put yourself in the T wave, going toward V1. If you see that QRS in your left side, left hand, that meaning patient has left bundle brush block. While if you see that QRS in the right hand, that meaning patient has right bundle branch block. It is simple, right? Then just imagine yourself in T wave and going to V1. When you have QRS in your left side, that meaning left bundle branch block. When you go to the right side, that meaning you have right bundle branch block. No need to look at V6, okay? But not always we can use this one, okay? But in general, use this one. You can judge about right bundle. This is normal pediatric ECG, but however, I can see that RS R prime, but here we call it just partial right bundle branch block, which is normal variant in pediatric. Then whenever you see that narrow QRS with RS R prime, this is normal variant in pediatric population, okay? We call it partial RV block, which is normal. No need to investigate the patient, okay? Then we'll look at QRS amplitude. Abnormal QRS voltage is an important criteria for LVH. Low voltage QRS we see is seen in hypothyroidism. Normal newborn, can we see that low voltage QRS? Can we see low voltage in myocarditis, pericardial effusion, chronic constrictive pericarditis, and we can see low voltage QRS in tachyhabitus if patient has obese, pregnant, all that patient have low voltage. I have to comment then about R wave progression in the ECG. Normally, as you know that, in V1, we see deep S wave and small R wave, right? Because all the dualization will go that toward the right, into the left ventricle, which is dominant. V1 will be small, and in V6 will be large R wave because the V6 get all the impulse from the left side ventricle. Normal progression of the R wave from V1 to V6 started by small in V1, then increasing V2, V3, V4, V5, V6. This is normal R wave progression. You have to comment in this one in ECG, okay? Then number 10, I have to comment on ST segments. As you see that normal BQRST segment, ST segment on baseline, the same PR baseline, while ST elevations above the baseline, we can accept in pediatric 3, sometimes to 4 millimeters ST elevation is normal, according to the situation, the clinical situation. ST depression that's below the baseline segment. Very rare to see ST elevation in pediatric. We see it on the, Kawasaki disease, as you see here, ST elevation. Widespread concave ST elevation and BR depression throughout most of the limb lead. We see it in pericarditis as well. You see that some ST elevation in pericarditis with PR depression in pericarditis. If you want to know that the stages of pericarditis, stage 1, there is widespread PR depressions and ST elevation. Stage 2 normalized. Then stage 3 flattening T wave, become inverted. Then stage 4 ECG return to normal, just several weeks. Then next, I have to check T wave. T wave changes. Usually, T wave changes associated with the condition manifested with pathological ST segment shift. T wave changes, we can see it in peaked. We can see peak T wave, hyperacute T waves, inverted T waves, biphasic T waves, camp humble T waves, or flattening T wave. You know that one big T wave here. We can see it in the hyperkalemia. As you see, we can see inverted T wave as well in the bundle branch block as well. Where we can see inverted T wave in normal finding in children, exclusively V1, V2, from 7 days to some reference 13 years, some reference 8 years until 9 years, we can see normally inverted T wave in V1, V2 only. Can we see it in persistent juvenile T wave patterns? Can we see it in myocardial ischemia and infarction, in Vandermesh block, ventricular hypertrophy, stern pattern, pulmonary embolism, hypertrophic cardiomyopathy, and raised intracranial pressure as well.
Dr.
Then I have to comment.
It's just like 5 minutes for the first break.
Yeah. Then we have to comment on the QT interval. This is normal ECG. The QT interval started from the beginning of Q wave and the end of T wave. More the issue is about how to determine that the end of T wave. This is a big challenging for us. It's very simple. Just take baseline here and just take another line just at the end of the T wave. The intersection point here will be end of T wave. Just calculate that. And then we have to correct that the QT interval because it's different according to the heart rate, related to heart rate. We have to correct that QT interval. The QT corrected will be equal QT, calculated QT divided on the square of the preceding RR interval. We'll take the RR preceding RR interval, we'll square it, and then we'll divide the QT on the square of RR interval, will give the QTC. Okay, so QT corrected. Normal range for QT from 1 to 15 years, less than 44 seconds or 440 milliseconds. Borderline from 44 to 46. Prolonged more than 46 in 1 to 15 years. In adult male, more than 45. In adult female, more than 47. But actually, we are as pediatric cardiology, we don't just depend on this measurement. Usually we use what we call it Schwartz criteria. We have a criteria for that. Not only the prolongation of QT, we have to check that clinical history of the patient. We have to check family history of the patient, and we'll give scores. If patient with long QT scored 3.5 and above, considered to have long QT. Okay. I have a trick also about how to determine this patient has possible long QT or no. Just put imaginary line here in the middle of RR interval. Take RR interval in the middle, just put imaginary line. If the end of the wave be before this line, that meaning patient has normal QT. If the end of T wave within the line or after the line, that patient possibly have long QT, even before to calculate the QT. Okay. Like this patient here, just put imaginary line here. See the end of the wave just after the line, that means patient has long QT. And at the last step, you have to put your impression or your diagnosis after all these steps. Then we have to go through ECG steps by step. I will share with you that this very nice paper we separate to our ER department here. Just if you work in the emergency department and you get his ECG, when to refer to pediatric cardiology. If patient has ECG red flags, what we call it, syncope, it's red flag, family history of sudden unexpected death, red flag, or long QT more than 45 or 450 milliseconds, red flag, you have to refer to pediatric cardiology. And this scheme here also, you can just go step by step about rate. If rate is okay, rhythm is okay, axis, P wave, all through the steps I mentioned before, that patient, and you don't have red flag, you can discharge patient. Otherwise, with any red flag, you have to refer to pediatric cardiology or to be seen by your consultant. Key points, just use a systematic approach for accurate interpretation of pediatric ECGs. Always interpret an ECG within the clinical scenario, not only just to look at the ECG. The age-specific limit of normal are an essential tool for accurate assessment. Senior clinician should always review abnormal finding of ECG, discuss all children presenting with any cardiac red flag with a senior clinician, even if an ECG appears normal. Further investigation, including 24-hour tape, echocardiogram, or exercise tolerance test may be required. Thank you very much.
Perfect, on time.
Yeah.
Thank you very much. It's been very brilliant talk.
Good.
And it's really useful. So any questions from the audience? We got like 2 minutes only, then we go for the break.
Any question?
Nothing yet in the chat box so far. Just a lot of thanks.
Okay.
Thank you for this talk. I think there is a question about the J-point depression on the chat.
J point depression is juvenile T wave. Will be some depression in G wave. We accept in the pediatric, we call it juvenile or juvenile T wave. Okay.
Thank you.
I had asked about the right axis deviation. Quick. I lost her.
Someone just about what? Sorry, what's the question?
The axis deviation. I think it's a bit tricky.
Okay, I will repeat again. There is some asking about Brugada syndrome. This one will be in next lectures. This lecture here just how to read pediatric ECG. Okay, I will re-explain about axis of the heart. Really very simple and very quick. You can answer the axis of the heart. See this ECG. This ECG in front of you, right? Where is located lead one to your body? Lead one on your left side when you look at the ECG, that when the ECG in front of you, right? Lead one located in your left hand, while AVF here located in your right hand. Okay? Then if QRS in general, QRS positive in lead one, that meaning your hand put it up. If positive, put your hand up. If negative, put your left hand down. Okay? While in AVF represent right hand, your right hand. If AVF positive QRS, that meaning right hand, put your right hand up. If negative in AVF, put your right hand down. Now, if left hand up and your right hand down, that meaning left axis deviation because it's up. If your right hand up and in left hand down, that meaning right axis deviation. If right hand and left hand two up, that meaning normal axis deviation. If your two hands or both hands down, that meaning this is the worst, north west axis deviation or extreme axis deviation. Is that clear? I hope that I explained well. For example, here, just see lead one directly, lead one, your hand here down, and if your right hand up, that meaning right axis deviation. Here, left hand up, right hand down, that meaning left axis deviation, because left hand up, which is left hand, my lead one, in my left. Right hand in my right hand down. Is that clear?
She said it's clear. Yeah, she replied in the chat box. Yeah. There is a few questions. I think it's very bulky topic, how to read the ECG. So we got a few questions. So Rida asked,
explain that bundle flow.
Yeah. So does AV block type 1 cause bradycardia? This one of the questions.
And AV, so what the question? AV block? Yeah.
AV block type 1.
You mean complete?
Yeah.
Type 1. Yeah. Usually, yeah. Usually that sometimes, yeah, the first degree block can make some bradycardia, but asymptomatic bradycardia. This patient no need any treatment. Even that normal variant, we can discharge him. You know that it's very, very, very common during the sleeping, the prolonged BR interval. Okay.
What is defined as short QR syndrome? This is another question.
The QR, okay.
QR syndrome. Yeah.
You mean QT, right? QT syndrome? Sorry, again?
It's written as QR, but I think I think they meant
No, QR syndrome. I haven't
but yeah.
heard about the QR syndrome. I think QT syndrome.
Yeah.
Yeah, QT syndrome. Usually, if the a QT as general pediatrician or as just junior pediatrician, if you have found that corrected QT more than 450 or more than 45 seconds, just contact pediatric cardiology if corrected QT. Sometimes really it's challenging even at a newborn because T wave will be very broad. It's difficult to judge where is the end of T wave. Okay, then as we are pediatric cardiology here, as pediatric cardiology, we don't just consider that long QT as QT prolonged more than 46. We have other things to determine that. Other criteria will follow that our criteria as well. Okay, just for you a general pediatric or junior pediatrician, just to knows how to calculate corrected QT. And nowadays that there is a lot of application in your mobile can calculate QT very easily. Just count how many millimeters and how many small square between that starting of Q wave and end of T wave. Okay. Then the QT syndromes, we have 3 syndromes, more than maybe 15 syndromes, but however, that one will be in next lecture, next days. I don't know when, but however in the future. This presentation just to how to read pediatric ECG, okay?
Right. So the people ask if you could get this presentation. It's a recorded session and would be published on the BSAPCH platform. So you find it shortly after this presentation. So don't worry.
Yeah, no worries.
For the people who ask, and someone asked about guidelines for after the surgery. I think there is a few questions. I'm not sure if we could just answer it all before the break. So how to spot Brugada syndrome on the ECG?
I thought it was really in different presentation. There is a lot of things, but however, COVID ST wave and V1, V2, COVID ST wave is most likely we can just predict that patient has Brugada syndrome. Even that you have to take clear family history about this because it's very rare at pediatric age.
Guidelines for complete heart block post-cardiac surgery, if there is any clear guidelines for this?
Yeah, that one, you mean not guidelines for complete heart block, you mean guideline for implant of permanent pacemaker, you mean, I think. It's complete heart block, any complete heart block within 7 days, and now they extended to 10 days. After 10 days post-surgery, if still patient has complete heart block or second or advanced heart block, that patient indicated to go for permanent pacemaker.
It's fine. We can answer these questions after they finish the talk at the end, I think, or anything left?
T-wave inversion V1, V2 would be normal at the age between 7 days until sometimes 10 years, sometimes 13 years. Some reference gives just 8 years. But however, will be normal between 7 days until 13 years. Inverted T-wave in V1, V2. And will be normal T-wave below 7 days, okay? Like adult.
Hi. Please, just need a little explanation about the sinus rhythm using the P wave. You were explaining that.
You mean how to determine sinus rhythm or not sinus rhythm?
Yes, yes, please.
Yeah, no worries. as we know, normally, this is the heart here. This is sinus node, and this is the AV node, right? Sinus node give the impulse toward AV node, from AV node to the heart. The B wave axis, the same axis of the heart, that being the B wave impulse in this direction. As we know that AVR, that in right arm of the patient, and lead 1 in left arm of the patient, and lead 2, lead 3, and AVF, if that meaning foot, that meaning inferior lead. Any impulse toward the lead will give positive deflection, while any impulse away from the leads, which is AVR here, the impulse away, right, normally will be negative deflection. That meaning B wave, if sinus, supposed to be positive in AVF and negative in AVR, okay? And should be every B wave followed by QRS, and should be every QRS preceded by B wave to tell sinus, okay? Is that clear?
Yes.
As here. B wave in lead 1 positive, which is normal positive because the impulse going toward the lead 1. Inferior lead, AVF, lead 2, lead 3, all positive because the P wave going toward the leads. While in AVR, negative P wave, right? That meaning because the pulse going away from the leads.
Yeah, thank you very much. And now we got like 10 minutes only for the break. If we could all get back to screens by, yeah, okay, 11:35. Thank you very much.
Thank you. Thank you. Bye.
Hello, welcome back. Got like 77 now. Hopefully you enjoyed this short break. Now we are resuming our day and we are moving forward to like quiz. It's just like a practical part of what you got from the previous presentations, like just to apply the knowledge you get already. So we will do some quizzes and it's like interactive, so feel free to share what you got from the previous session. And it would be presented with Dr. Mohamed Badawy, our next speaker. And he is pediatric clinical, he's a pediatrician because he had his CCT in 2023 with a special interest in pediatric cardiology. However, he tried to get more experience in pediatrics by doing a special pediatric cardiology. As you know, it's different specialties. So he secured a training, national training number in this very competitive training. So well done, Mohammed. And he had master's degree from Egypt in clinical pediatrics from Cairo in Egypt. And he got a postgraduate certificate for postgraduate education from Buckingham University. So it's very rich CV. And he achieved European certification in congenital heart disease in 2023. And he used to be RCPCH trainee representative and regional representative of East of England. And he had some certificates in leadership and management as well. And he is MRCPCH theory examiner trainee in 2021 till 2022. Nice to have you today, Dr. Badawy.
Thank you. It's a pleasure to be here.
We are so lucky to have you today. It's an honor.
Thank you so much.
Thank you. Could you start the quizzes, please? Can you share your slides, please? We can't see it yet. we can't hear you. Can you hear me?
This is as loud as I get.
Sorry, I thought you said you're gonna do some quiz first, or you want me to start my presentation?
Yes, please.
Okay.
Thank you.
Sorry. So can you see my presentation?
Yes.
Okay. Yeah, I mean, I'm gonna speak about ECGs in pediatrics, and I think Dr. Abdah has um, build up a great base for us to continue on. There might be some repetitions, however, it will be good for refreshing. This presentation is aimed to be very interactive, so I highly recommend that you switch on your cameras and your microphones, please, because I need you to speak up. This is a safe learning environment, so there is no right or wrong. Please say whatever you feel is correct for you, and we are learning together, as I said. This is a limited ECG experience to the general pediatrician, so I'm not going into too much details of the sophisticated pediatric cardiology ECG, but these are clinical scenarios from what you really see in your daily life practice. Again, it's a very interactive session. You need to speak. Please feel free to interrupt me at any time. Okay, if you have any question. Okay, are we ready to start? Let's go. What I want to say is when you look at an ECG, you shouldn't be looking separately at the ECG. You should look at your patient as well. What can you see in this ECG on the screen? Guys, you need to switch on your mics and your cameras. As I said, it's a safe learning environment. You need to speak. I'm not going to speak to myself.
Asystole.
Asystole. Okay, do you think this patient has asystole?
No.
Yeah, so what other possibilities are there? The ECG might be broken, the leads might be improperly positioned. So what this is very important. You can't look at the ECG separately. You have to look at your patients as well. You need to take a good history and perform a clinical examination. So all things are together. Okay?
Dr. Badawy, sorry,
yeah.
could you put it on the slideshow because it's not very clear for the audience and
Okay.
slideshow. Yeah, thank you.
Yeah, I just yeah. If you just help me with if there is any questions, if somebody, because I can't see now people. Okay.
Perfect.
So our objectives today is to understand the differences between the benign variant and the pathological variants of the pediatric ECG, to recognize the red flags of the ECG finding, and to be able to make a proper ECG diagnosis. If you have been a trainee in East of England or East Midland, you probably have heard that before. So please consider this as a refresher for you. I'm not going to speak about the basics. Dr. Abdah has already spoken about the basics in much details, and hopefully this will help us to build up the experience and the knowledge in the next few slides. Yeah, you can test yourself whether you can determine whether this ECG in the following cases is normal or abnormal. And if it's abnormal, what is the abnormality? So let's start with the first case. This is a 3-year-old child presented to the PEU, Pediatric Assessment Unit, or CEU, wherever you work and you call it, with the first episode of non-febrile fits. There is family history of epilepsy. The grandfather has died of heart attack at the age of 74. And as you know, any non-febrile fits, as a part of the workup, we do an ECG. But before looking at the ECG, is this history concerning from a cardiology perspective or no? What do you think?
No.
No.
Despite the grandfather has died of heart attack at the age of 74, any red flag?
It's not
No.
a young age.
Not really.
No.
So yeah, but as I said, as a part of the workup for non-febrile fits, we have to do an ECG because sometimes there are some rare cases that can be associated with fits. So this is the ECG. What do you think? Have a look at the
complex tachycardia.
complex tachycardia. Yes.
Ventricular tachycardia.
Ventricular tachycardia. Yes. Yeah, I think this is when the first look at this is that's what I'm gonna say. So what's your next action of plan? What's your next step? Are you going to give adenosine? Are you going to DC cardiovert? Are you going to call the pediatric consultant? Or are there any other options you can think of? Again, this is a safe environment. There's no right or wrong here. You are the pediatrician. You've seen this patient. You've seen this ECG. This is your action now. Physicians?
We can
How's the
we can
pulse?
add
Sorry?
ABCs first, make
Okay.
sure go ABC stepwise, airway, breathing, circulation,
Yeah.
and of course call for the senior.
Okay. So again, what did I tell you before? When you look at the ECG, you don't look separately from the patient. So look back at the ECG again. I'm sorry, I did bought this ECG at first to trick you all. This is a tricky ECG. Can you have a look here at lead one? What can you see in lead one? Is it normal or abnormal? What do you think, guys?
Sinus.
So yeah, sinus. Excellent. And here in V1, what do you think?
I think artifact.
Yeah, so this is artifact. This patient is presenting with fits. There is lots of body movement that can give you what we call pseudo ventricular tachycardia. So again, when you look at the patient, don't look separately from the ECG. Most likely the patient is stable. Do you think a patient with ventricular tachycardia is going to be stable? No. So this is an artifact, and artifacts are very, very common in pediatrics. They move a lot, they've got lots of movements, and sometimes it's really hard to get a proper or a pristine ECG. So you might have to repeat it again. So the artifacts are defined as ECG alterations that are not related to any cardiac electrical activity. As we said, they can be caused by various factors such as motion, electrical interference, if there is any metal things with the patient, coins, how to differentiate the artifact from the ventricular tachycardia. The first thing, as I said, and I always say, look at your patient. If there is absence of hemodynamic deterioration during the event, this is unlikely to be ventricular tachycardia. You have seen normal QRS complexes within the artifact. Do you think in ventricular tachycardia there will be normal QRS within? No. And I will show you again, there is unstable baseline on the ECG before the event, after the event, or both. And usually there is associated body movement. So look back again at the ECG. Look at the baseline. It's not stable. It's here. It's up, down, up, down. It's like, and then there is normal QRSs. Like, it looks even like going into VF, which is not the case if the patient is hemodynamically stable. So hopefully because sometimes you find abnormal finding on the ECGs, which doesn't make sense when you look at the patient. So keep in mind always that the leads might be improperly positioned. Okay, so that was tricky. Okay, but hopefully you got the message from this ECG. Okay, now are you ready for the second case? So again, pseudoventricular tachycardia, you have sinus sign. You can see in between there is normal sinus rhythm in between, okay? And the spike signs when you see irregular or regular tiny spikes among the white QRS complexes. As you can see, you can't tell how bad or normal is it if just looking at the trace. Is it wiggly or straight? Okay. Again, you have to carefully look at your patient, examine your patient. You have to look combined at the patient and the ECG. Ready for the second case? This is a 14-year-old boy brought to the ED with chest pressure and mild dyspnea. On examination, the blood pressure was 108/50. The heart rate is 60, but regular. He has a tender chest wall. Again, what do you think about this history? Are you worried from a cardiology perspective? Are you not worried? Chest pain is a very common presentation to the ED. Creates lots of anxiety. I'm going to assure you all, more than 90% of chest pain cases in the children is non-cardiac. It is non-cardiac until proved otherwise. Sometimes even if you got some abnormalities on the ECG, and I'm going to show you some stuff that might make you worried. But again, with this history, are you worried or not worried?
No. Most
No.
answers not. word.
Yeah, but you might need more information. This is not enough, isn't it?
Mhm.
Yeah.
Yeah.
Again, I need to assess the patient. I see the
Yes.
patient myself
Yeah,
and
I did.
assess ABCD.
Yeah.
Yeah.
Yeah, excellent. I didn't tell you anything about the examination. So when you tell me a story, when you are referring a story like this to a cardiologist, you might need to tell more information. I mean, the only assuring way, he's got a tender chest wall. This goes with cardiac or non-cardiac?
Non-cardiac.
Non-cardiac, yeah. As we know, what is the most common cause of chest pain in children? Osteochondritis or musculoskeletal. Okay, anyhow, let's have a look at the ECG. You decided to do an ECG, which is fair enough. You did an ECG. This is the ECG of a 14-year-old child. Just for the purpose of time, Dr. Abdul mentioned that we have to follow a scheme, which is important, but just because of our time, we need to go through as many ECGs as we can. Can you spot the abnormality if there is anything abnormal? It might be just normal. Depends on what you think. What do you think, guys? So I can't see you all, so just to speak up. Tell me.
There might be left ventricle hypertrophy.
Left ventricle hypertrophy. Excellent. This is a good point. Why did you say that?
Because very high voltage in
Yeah.
V5, V6.
Yeah, keep that in mind. I'm going to speak about that in another ECG, but this is a very good point. Okay, this is a good suggestion. Any other suggestions?
Is
This is
right
not wrong,
axis
by the way.
deviation?
Sorry, what?
Right axis deviation.
Right axis deviation. Excellent. This is a good pickup as well. What else? I'm going to speak about these other stuff as well.
For me, it looks normal axis.
It's right axis. You know, when you look at the lead one and AVF, it's right axis. Okay, but
So the P wave is not clear.
yes, excellent. Can you see B waves? I can't see any B waves. Guys, can you see any B wave? Do you agree with me that there is no B waves? Do you agree or not?
Yes.
Yes.
Yeah. So what Dr. Abdul mentioned about having a normal sinus rhythm, you need to have B.
P wave preceding every QRS with
Excellent.
a positive in lead 1 and AVF, negative
Yes.
in AVR.
Positive in the inferior lead. So here we don't have a B wave. So is it a normal sinus rhythm?
No.
No. So what is that? Anybody who attended this teaching before can tell me?
Lux junction.
Excellent. So this is junctional rhythm. We call this just a junctional rhythm. What does junctional mean? So if the impulse is coming from the SE node going to the atria, then the AV node, you will have a B wave followed by a QRS. But now the pacemaker is in the AV node itself. So we are missing the atria here. So there is no B wave because the SA node or the impulse is coming from the AV node itself or from the AV junction itself. And this is the reason we call this junctional rhythm. Okay. Okay, so you got the diagnosis. As you said, I can see here, there's no big waves. Okay, now, what is your next step in management of this patient? You got the diagnosis, very well, well done. Regarding the stuff you guys mentioned about the tool R wave in V5 and V6 and their axis division, I'm going to speak about that, but in different ECGs, just to focus on one thing. So are you going to arrange for urgent echo? Are you to give atropine? This patient is bradycardic, by the way. Are you going to do nothing because you might think this is benign? Or are you going to speak to cardiology, which is fair enough if you're not sure? Again, as I said, there is no right or wrong. What are you going to do in the ED?
Do nothing.
Sorry?
Do nothing.
I may discuss with cardiology first.
Yeah.
I will discuss with cardiology.
Okay, fair enough. Fair enough. Okay, but this is one of the common presentations in the pediatric ward. You might you might speak to cardiology to assure you, but again, junctional rhythm is a very benign phenomena in children. You see that rhythm is regular, absence of B waves. This is always benign in children. Okay. Again, you have to look why this patient have a junctional rhythm. It is caused by acute stressors such as infection, oxygen desaturation, stimulation of the vagus nerve. So sometimes toxicology, sometimes drugs. If the patient has paracetamol toxicity, for example, if he's got viral infection, he can have this junctional rhythm. It is benign. I'm not worried, but you might would like to speak to pediatric cardiologist to assure you. He said, okay, this junctional rhythm, it's benign. Well, I'm not worried. You might just need to repeat the ECG in 2 to 4 weeks to make sure it is normalized. Okay?
So I may ask a quick question.
Of course, go for it.
This can be the cause of the chest pain. I don't think it's related, just incidentally discovered. Yeah.
Do you think it is the cause of the chest pain?
No, but I mean, this rhythm cannot cause any chest pain, just so.
No. It's just, and what are the cause of chest pain? He might have some sort of viral infection causing chest pain, and this is when you have viral infection, you can have junctional rhythm as well. Okay, what I want to say is, because there is, you are gonna do only the ECG if you have symptoms like chest pain, but don't get excited if you have junctional rhythm with chest pain, especially if you don't have any red flags on the chest pain.
So
Okay?
would you do a 24-hour tape, something that halter?
I mean, if you are worried enough, you might would do it. I wouldn't do it. I would just repeat the ECG in 2 to 4 weeks to make sure it is normalized. Okay. As I said, as a cardiologist, we're not bothered about junctional rhythm. It's benign. We know it's benign. It's common. It's common. And this is the message I want all the pediatricians to know. Don't get too much excited about this. But it's reasonable to look for the reason. The child has got infection, got any stressors that might cause junctional rhythm. I'm not speaking about a child who has a cardiac background. I'm not speaking a child who has a post-operative open heart surgery. Okay, you need to look carefully for your red flags.
And just had there been a like a heart block, then we would have seen like how would it have been different?
Is it heart block?
No, in a heart block, we will find a P wave and then progressively increasing.
There are
And
three
then
types of heart block. There are 3 types of heart block. Dr. Abdah spoke about them. This is completely different to heart block. This is a regular rhythm with absent P wave.
Okay.
Okay. Hopefully, just that to make things clear, don't confuse things together. Okay. Does that fit into any criteria of heart block?
No.
No. So you answered yourself. This is not heart block. Excellent. Okay. Any other questions before shifting to another case?
Yeah, yes, please. One question, please.
Yeah.
I know this is a junctional rhythm.
Yeah.
There is other 3 foci other than the SE node that can cause the bradycardia.
Yeah.
So the question is, what is the difference if it is from the other foci? And what is the approach? Is it the same? It could be benign, and I will repeat the ECG in 2 to 4 weeks.
So, this is as I said, this is junctional. It can come from the atria, and it can be atrial tachycardia. It can come from the ventricles. Okay, it can be ventricular tachycardia. Again, this is completely different to junctional rhythm. Okay, and this is pathological. What I am focusing here is on that pattern that you will see on the ECG. You're speaking about different things as atrial tachycardia, ventricular tachycardia, or types of heart block. What I want you to keep in mind: this rhythm, regular, absent P waves, it is benign. Okay, I'm not worried. I will just repeat the ECG in 2 to 4 weeks. But other stuff might be different, which is not the same as this ECG. We might touch on other stuff here as well.
Sorry, can I interrupt?
Yeah, of course. Yeah, go for it.
Someone said there is a left ventricle hypertrophy, and you agreed.
Yes,
So
I agree. I partially agreed.
Yeah.
Okay, I'm going to touch on that because this is very important. I partially agreed before analyzing this. Okay, keep also in mind this pattern. Can you see my cursor?
Yes.
Yeah. Can you see why he mentioned? Can you see why he mentioned left ventricular hypertrophy?
On V5 and 6, the QR is high, isn't it?
Okay. However, I'm going to destroy this. What did you say about the axis?
Right.
So do you think left ventricular hypertrophy will come with right axis or left axis?
Yeah, usually left.
Yeah, so this is questionable now, isn't it? But if you mentioned that, it's fair enough. You can see a very high R wave in V5 and V6, isn't it?
Yeah.
Yeah, I'm not going to say you are wrong, but we're going to analyze this later. Okay, I'm just focusing on the junctional rhythm in that one. Okay?
Yeah, I mean, just a question. We are pediatrician. If I have now junctional rhythm and possibly hypertrophy hypertrophic left heart. Is
Yeah.
that something to worry about, or
Okay, one second. Do you think this is left ventricular hypertrophy with right axis deviation of the heart?
No? I mean, this
Okay.
doesn't match.
Yeah, again, this
Yeah,
how old this one? 14 years old.
14-year-old
So
boy.
if there is left ventricular hypertrophy, what would you think the heart will look like on on X-ray?
It should be cardiomegaly.
So the ECGs are mainly to diagnose electrical activities. Left ventricular hypertrophy or right ventricular hypertrophy, though the ECG is helpful, but it should not be used to diagnose. The diagnosis is by echo.
Okay.
You know, but again, there is lots of controversies here about the LVH. However, it is confusing. It's fair enough, okay? And I'm going to speak about that in more details in another cases. But I
Yeah.
get your point. But always do a chest X-ray. He's got chest pain. He might have pneumonia, might have whatever. If the X-ray didn't show cardiomegaly, it's unlikely in a 14-year-old, because if you got left ventricular hypertrophy, this means about something has been going on for some time, and you will probably have a cardiomegaly in an X-ray, isn't it?
Yes.
And there is also other findings I'm going to speak to you about. I'm going to show you, don't worry, I'm going to speak about that in more details. I just like focusing on the junctionism on this ECG. But it's because it's a good point, I just highlighted it now to keep you more excited. Okay? Let's go for the second case. This is a 15-year-old. Sorry, I can't say, sorry. I don't, sorry guys. Yeah, this is a 15-year-old boy, has a syncopal episode during his first high school basketball game. He was brought to the ED by the ambulance for evaluation. Again, with this short history, are you worried or no?
Yes.
Yes.
Of course.
QT.
Sorry? Whatever you will find. But if you have a syncopal episode during exercise, this is
Red
really
flag.
worrying. You
Yes.
still you know what? Even if you have a normal ECG, you still have to speak to the cardiologist. This is not, you shouldn't be accepting that. Okay? Even if you have a normal ECG, you should be worried. Having syncopal episode during exercise is one of the red flags for us. But just have to be careful. You have to get a detailed history. Has the syncopal episode happened during the exercise or after the exercise? Because sometimes you get tired after the exercise and you just fall down. Okay, this is different to have the syncopal episode during the exercise. Is that clear, guys? So I can't see you, so you might be nodding or something. I'm not sure.
Yes.
So
Yeah.
you will not be worried if it's at the end of the exercise?
Yes. At the end of the exercise, I'm not worried. Okay. During the exercise, I'm worried. Even if I have a normal ECG, I still have to speak to the cardiologist.
I mean, still at the end of the exercise could be the same reason, isn't it? It's
No,
like,
usually it's due to tiredness. During the exercise, during the activity itself, it's different from after the activity.
okay.
Okay. Now, as I said, again, even if you have an ECG, please speak to the cardiologist. Okay. But you did an ECG. This is the ECG. Look carefully. I'm going to point the abnormal points, but here you've got so many things that we can talk about. It's an open discussion. Tell me, what do you think? Any suggestions? Do you think it's normal? Again, if it's normal, that's fine. I still have to speak to the cardiologist anyhow.
Is the QT, I mean, we didn't calculate
Let me make it easy for you. QT is normal here.
It's got some dagger Q waves, I'd say. So
Where?
possible hypertrophy.
Yeah.
So basically talking from V3 down to V6. So we need to consider hypertrophic cardiomyopathy in this case.
Yeah, where is the Q waves in V3 to V6? Sorry.
It's a deep Q wave, I'd say, in V4 up to V6.
V4.
V3 actually up to V6. We can.
Do you think this is a deep Q wave?
It's arguable in V3, but V4 to V6.
Sorry? Okay, I'm gonna speak about that in details. But what do you think about lead one? Key wave in lead one? What do you think about key wave in lead one?
We
What do-
can't lead one.
Sorry?
We can't
cannot.
see lead one.
So
There is
this
no 1, 2, 3.
this is I don't know why my cursor is not working. Sorry, guys.
No, the whole diagram doesn't show lead 1, 2,
Okay,
3.
I don't know.
So I think only there is septal hypertrophy showed in V3 and V4.
Yeah, I'm just trying to figure out why not you can't see. Yeah, can you see lead one now? Sorry, I don't know why it's probably it's larger than enough. Can you see lead one?
Yes, here we can.
Yes, we
Yeah.
can, yeah.
What do you think about the Q even lead one? Almost 5, yeah, 3 millimeter or something, isn't it?
Narrow.
Yeah, but it's quite large. I'm gonna speak about that. What do you think about Q wave in AVL? There's Q waves, huh? Okay, I'm gonna confuse you more. What do you think about Q wave in lead 2? This Q wave, huh? Okay.
I
Now,
think normal.
sorry?
I think ECG is normal except the septal hypertrophy.
So if no, you are saying two different stuff. You say the ECG is normal and then you see septal hypertrophy. So
Yes.
it's either normal or septal hypertrophy. It cannot be both. It's
لا
septal
لا I
hypertrophy
mean there is
final.
no abnormality in QTC, but
Yes.
the only positive thing in the ECG is a septal hypertrophy.
Okay, let me guide you to something else. What do you think about R in V1 here? Look at R in V1 and look at R in V2.
Yeah, the R progression is not great. The R
Excellent.
progression.
Excellent. So you would expect R in V1 to be the same, if not less than V2, isn't it?
Yes.
Yeah, but R here is quite large in V1. Might be not that large, but if you compare it to V2, it's larger than it. So we're kind of losing the R wave progression here, which is a very good pickup. Somebody has mentioned that might be hypertrophic cardiomyopathy. If you have a look here, lead 1 and EVL, guys, please listen carefully to what I'm saying. You shouldn't be seeing any Q waves in lead 1 and EVL. If you see Q wave in lead 1 and AVL, this is abnormal. In pediatrics, you shouldn't be seeing any Q waves in 1 and EVL. Always remember that. Having large Q waves in 1 and EVL is always abnormal. If you think the child does not, just repeat the ECG. Let's have a look again. Okay? And as I can't remember who mentioned, is it Mohammed who mentioned that septal hypertrophy? Yeah, sorry, I don't have the names in front of me.
Yes,
Yes.
Ahmed Najib.
Somebody has mentioned about the septal hypertrophy. That was excellent, and he picked the Q waves. Again, the subtle thing is the R wave here in V1, and when you compare it to V2, going back here, when you compare it to V2, it's larger. So what does this denote? So always remember. Do you remember where we bought V1 lead? When you bought how do you bought the lead on the chest? Where is V1? Where do you bought it?
Right.
Right side.
Right port intercostal
Yes. And where do you bought V6?
At the X
mid
left X.
axillary line, left.
Excellent, Ketchy. So I'm always saying V1 is the land of the right ventricle. V6 is the land of the left ventricle. So if there is anything abnormal in V1, this means there is abnormality in the right ventricle. If there is anything abnormal in V6, there is abnormality in the left ventricle. So if you have a prominent R wave here in V1 in older children, that might mean there is right ventricular hypertrophy. Okay? So what structure abnormality is suggested here? I think you pick this, and it is hypertrophic cardiomyopathy. You've got septal hypertrophy, as you've seen. You've got Q waves in 1 and EVL. You've got prominent R wave in V1, and these are all abnormal, and this goes with the hypertrophic cardiomyopathy. So having prominent R wave in V1, I'm speaking about older children. I'm not speaking about neonates. because in neonates, as you know, you will have a prominent R wave in V1. This is completely normal. I'm speaking about older children. Again, I have to highlight this again and again and again. Q waves in lead 1 and AVL is always abnormal. Okay? Always abnormal. So you have to do an echo, you have to speak with cardiology. This is a red flag. The history itself without the ECG is a red flag. Okay, guys, do you have any questions regarding this? You might have lots of questions. Hopefully, I will answer in the next few slides.
Do you mind to say the finding again in text and the ECG, please?
Sorry?
Just highlight it. Do you mind to say the finding in the ECG, please, again?
Yeah. Can you see the ECG with me?
Yes, yeah.
Okay. Look here at 1 and AVL. This Q wave here. What is the Q wave, by the way? The first negative deflection after the B wave. So this is the B wave, the first negative deflection after the B wave. This is a Q wave. As we said, this is like, even if it's like 3 millimeter, but we're not expecting to see Q waves in children in 1 and EVL. Okay, so this EVL, this is abnormal. The other thing here, there's a prominent R wave here. How do I know it's a prominent? When looking at V2, R is small. Normally, R wave starts small in V1 and increases gradually from V1 to V3 to V3 to V4, V5, and its maximum in V6. Why? Because in older children, the left ventricle is the dominant ventricle. So the power all on the left side, not on the right side. But here you're starting having a larger R wave than in V1 than V2. This means there's something wrong here with the right ventricle, which is right ventricular hypertrophy. So combination of both these things might lead you to the diagnosis of hypertrophic cardiomyopathy. You need to do an echocardiography. You need to speak to cardiologist. Okay?
Yes,
Is that
thank
clear?
you.
Do you have any questions?
No, thank you.
Let's go for another case. There is
a question in the chat, Mohammed,
Yeah.
about what the septal hypertrophy here.
Again, 1 and AVL. The Q wave is the Q wave in electricity. The Q wave is coming from the septum. Okay, so that when you have a prominent Q wave, this means septal hypertrophy. When you go back to electricity, the Q wave usually this is so the QRS complex in general. This is related to the ventricular depolarization. Okay, the first part of the ventricle that is depolarized is the septum, and usually the septal depolarization is the Q wave. When you've got a large Q wave in 1 and AVL, this means there is abnormal septal hypertrophy. So what do you need to septal hypertrophy here is the prominent Q wave. Again, in a normal ECG, you shouldn't be expecting to see a Q wave in 1 and AVL. Is that clear? Hopefully it is clear. Okay, let's go to another case. This is an 11-year-old girl. She's being evaluated in the pediatric assessment unit for low-grade fever, rash, easy fatigability. Just putting something to guide you to something. She has recently visited the Scottish Highlands with her family. Whatever this history means for you, she's been previously healthy and has no palpitations, chest pain, syncope. For some reasons, you decided to do an ECG. You are not sure what's going on with her. You did everything. You did this ECG. But regarding this history, are you worried from a cardiac perspective or no?
Yeah, because the syncope, low fever, rash.
I didn't mention about syncope, did I?
You said, I think.
No. Low fever, rash, and easy fatigability.
Okay, sorry then.
Are
I mean,
you-
still endocarditis, one of the things, or
Endocarditis with low-grade fever, very short history.
Mm,
Yeah,
The
I mean,
history
you need
can
to have a line, central line. You need to have something. You know, normal children doesn't have
yeah,
endocarditis for no reasons. Just
um,
think carefully about your history.
rheumatic fever, whatever.
Well,
Yeah,
you know.
I will be afraid because of suspicion of myocarditis, I think.
Anyhow, you did an ECG. Fair enough, myocarditis. This is the ECG. Just to spot the abnormality on the ECG. Guys, we've got lots of ECGs. Hopefully you can.
Can you enlarge your screen, please, Mohammed?
Okay, sorry, because I realized that when I enlarge my screen, I missed some stuff. Let's do that.
So you go for
First degree heart block.
options and make it at 50% or less so you can see the screen.
That's fine.
Yeah.
First degree heart block.
Sorry?
I think there is
First
prolonged
degree
PR
heart block.
interval.
Excellent. Prolonged PR interval. Somebody mentioned about what degree of heart block?
First degree.
First degree. Are you worried? Not worried? Are you going to speak to cardiologist or no?
No, no worry.
Are you
Normal
sure?
finding.
There's
Okay.
also left axis deviation. So you can consider a bifascicular block in this
No,
case.
I'm gonna. Do you think this is left axis?
It is a left axis.
Yeah, we have to do the calculations, to be honest.
Okay.
Yeah. But the most prominent thing here is first degree heart block. But given this history, anyhow, let's give you some guidance questions. What's the next step? Do nothing? This is benign.
Irrelevant.
Sorry?
Number 8. We'll do nothing.
We'll do
So
nothing.
we'll
Obtain
do
echo.
D.
No, we'll go with Lyme disease.
Okay. So why Lyme disease?
Travel.
She went to the highland and she had like symptoms of rash, easy fatigability, and low grade
Yeah.
fever. So
Excellent.
symptomatic.
That's excellent. I didn't put that history for no reason. I just put it to guide you to that. So it's very important to ask about travel history and don't, as I said, don't interpret the ECG without looking carefully at the history and the examination. So as somebody mentioned, the first degree heart block is a normal variant in pediatrics. We don't get excited about it. It's a result of increased vagal tone, particularly in runners. Asymptomatic first degree AV block, guys, does not require any further workup. Don't ask for echo. Don't ask for a 24-hour ECG. You might talk to cardiology to make sure that your decision is correct. However, in many congenital, infectious, or toxological conditions might cause prolonged PR interval. So you would like to look for a reason. Lyme disease is a very famous disease that causes first degree heart block. Okay. So you might need to do the Borrelia screen, especially with the history you have. Repeat your ECG in few weeks to make sure it has returned back to normal. But first degree heart block on its own, we don't get excited about it. Just let's go to another case. This is a 12-year-old boy, athletic, came to the AD after he experienced chest pain. Upon arrival, he has a reproducible chest wall tenderness. The parents insisted that they should have to be referred to cardiology, which is very common, as a school friend recently died during sporting event. The ECG is noted to be abnormal by the machine. Given this history, are you worried from a cardiac perspective or no?
No.
Why?
Chest wall tenderness. So costochondritis is the most likely.
Yes, excellent. And this is all I always, when I get a referral, is the chest pain reproducible or no? What does it mean, guys? Do you know?
No.
What does it mean? What does reproducible chest pain
I
mean?
think it means when we press to the chest, I ask him, is this the same pain that you feel at the start?
Excellent. And this is a test you should do for any chest pain because the cardiologist will ask you, is it reproducible or no? If you told me it is reproducible, I'm not worried. Okay, what about the story that there is a school friend that died recently during a sporting event? Is it relevant to call the cardiologist for that?
No.
No, of course
No,
not. No, don't do that. Okay. Anyhow, the machine reported it as abnormal as usual. I want you to have a look at the ECG. Tell me, do you agree with the machine or not? How old is he? He's 12, okay? Yeah. If you think it's abnormal, fair enough. If you don't think it is abnormal, you need to tell me why did the machine mention it is abnormal?
I think the machine said abnormal probably because of the T-wave inversion in V1 and V2, which in children is normal.
Excellent. That's a good pickup. Okay. So if you look here, the machine picked inverted T wave in V1, in V2, and in V3, it is flat. Okay. So Dr. Abdah has spoken about this. I might just to highlight this in more details or just make it in a different Yeah, language. So what are you going to do? Obtain troponin PNP, he's got chest pain, arrange 24-hour ECG echo, refer to cardio, reassure the patient and his parents, admit for observation. Honestly, what are you going to do?
Reassuring.
Yeah. Okay, so this is very important. You have to be confident in your decision. But after doing, if you are confident in your history taking examination and interpretation of the ECG, you don't really need to speak to cardiology. You don't really need to do troponin and BNP. However, I understand the difficulties, parents and anxiety. Sometimes you may need to do some stuff you don't necessarily need to do. But with this ECG, I wouldn't do anything. Speaking about the T-wave, T-wave is in the pediatric world is very confusing. It is very dynamic, by the way. So T-wave inversion in the right precordial leads, I'm speaking about V1, V2, V3, is normal in children. Okay, it is dynamic throughout childhood. What do I mean by dynamic? It is changeable. On the other side, if you have a positive T wave in V1 at young age, this is abnormal. Okay, so if you have, again, always remember, if you have a positive T wave in V1 at young age, always remember this is abnormal. Speaking about the T wave, guys, you know, when you are born, it's just similar to when you are an adult. Okay, so when you are immediately born, your T wave is positive in V1. Let's focus on V1. Okay, so at birth, the first 7 days of life, the first 3 to 7 days of life, your T wave in V1 is positive. This is normal. Okay, how long does it persist positive? Usually after day 7 of life, it should be negative. Okay, just to make it easy for you, from day 7 to year 17, it is negative. You will find some textbooks mentioned till year 10, year 13, year 14. Even some adults might have persistent juvenile T wave negative in V1. So if you have isolated negative T wave in V1, or not bothered, even an adult. Okay? Again, T wave is positive from D0, let's say, to D7. T wave is negative from D7 till year 17. Okay, I'm speaking about V1. Okay, and usually what happened is, so T wave when you are a baby, it get inverted in I'm not sure if you can see my cursor. It get inverted in V1, V2, V3, V4. Okay, remember this, T wave shouldn't be negative in V5 and V6 at any age. Again, I'm going to repeat this because it is very important. T wave shouldn't be negative in V6 at any age. If T wave is negative in V6, this is abnormal. Always remember this. If T wave is negative in V6 at any age, this is abnormal. So when you are born, you have an inverted T wave in V1, V2, V3, V4. V5 might be flat, inverted, positive. V6 is positive. Okay, when you grow up gradually, so you are year 1, year 2, year 3, year 4, so your T wave started to be positive from the other way around. So for V4 first get positive, then you grow more. V3 get positive, you grow more. VT get positive, then the last thing to get positive is V1, or it might not get positive at all. Is that clear? Or did you get more confused? Is that clear, guys?
I think it's
Yes.
Clear.
Has anybody got any confusion regarding this? And this is the juvenile T pattern that Dr. Abdou spoke about. Okay, hopefully that's clear.
And for how long this should be inverted? I mean,
Yeah,
from
I
V1
told
to
you,
V6.
from day 7 to year 17.
17, sorry, I missed
Yeah.
that.
I'm just making this number to make it easy for you. You will find some textbooks mention day 10, day 13. If you find this in a year 17, or not bothered. Even sometimes in adults, they have isolated negative T wave in V1. It's normal. It's just persistence of the juvenile T wave pattern. Is that clear? Hopefully it is clear.
yeah.
Okay. Yeah, so we spoke about the T wave, and I said if you have it on the other way around, if you have, let's say, if you have a 2-week-old child, okay, and he's got a positive T wave in V1, this is normal or abnormal? I need to hear somebody.
Abnormal, abnormal.
What could it be?
It's a bright T wave.
In V1, what could it be? What is the abnormality?
It's a positive after 7 days.
Yeah, so if you've got now a positive T wave, sorry, it's negative after 7 days, you mean?
Yeah.
So if I've got a 2-week-old child who's got a positive T wave in V1, it's abnormal. What do you think of? What's your suggestion?
Hyperkalemia?
Nope.
Right ventricular hypertrophy.
Excellent. I heard somebody here saying right hyperventricular hypertrophy. You know, guys, that could be the only sign for right ventricular hypertrophy in babies, because at this age, they still have right ventricular dominance, so you can't rely on RNV1. Okay, another case. You got a 10-year-old girl brought to the PEU by ambulance. She fainted after having a hot shower at home. The AD doctor felt the heart rate might be irregular. This is a true story, and there was a soft systolic murmur on auscultation. Are you worried from a cardiac perspective or no?
No.
Because of?
No.
Yes, no? Mm-hmm.
Yeah, yes, because of the
Yes.
irregular.
Irregular heart.
And heart murmur.
You know what, guys? Yeah, working as a pediatric cardiologist, right? I've got so many referrals like that, which is, yeah, it's not nice to tell me irregular heart rate while you're having this ECG. Can you have a look at, because when you tell me irregular heart rate, what do you mean? What will come to my mind? Sorry, what will come to my
Respiratory
mind?
arrhythmia.
Yeah, but when you tell me irregular heart rate, I will think of arrhythmia, isn't it? I will think of abnormal heart rhythm. So with this ECG, is it sinus rhythm or not sinus rhythm?
Sinus respiratory variation.
Yeah, respiratory.
Sinus arrhythmia.
Yeah, so that might give you the impression that the heart rate is irregular, isn't it? But when you do the ECG, when you have a B followed by QRS in each lead, we've got a positive B wave in 2, 3, and EVF. So do you think there is any sort of arrhythmia here?
Only respiratory variation, respiratory arrhythmia.
This
Normal.
is universal in children, which is normal. Do you think you should speak to the cardiologist?
Absolutely not.
Yeah. And what do you think about the irregular heart rate?
Respiratory variation.
Yeah, can you tell me more about that?
During inspiration, heart rate is increasing, and during expiration, heart rate is decreasing. This normal variant.
Excellent.
And
Okay, what about the soft murmur? Have you missed that?
The innocent murmur.
Yeah, but sometimes we are not sure, so we still have to speak to the cardiologist. I'm happy to speak to me about a murmur, but about a normal ECG, usually people don't like it. Okay. Yeah, so as you mentioned, this is a sinus arrhythmia, which is exaggeration, but normal variation of the sinus rhythm. This is universal in children. This, you need to know that this is common in children. Okay. No further testing is needing. No 24-hour ECG is needing. Probably depending on the quality of the probably innocent flow murmur ECG, echocardiography may be warranted. However, I might just need to listen again or ask the GP to listen again in a couple of weeks. If it's persistent, I will refer for echo. We've got so many referrals for innocent murmur. If you are not sure, it's fair enough to refer. It's not a problem at all.
Dr. Badawy, we got 7 minutes left. If you would
Yeah.
using some ECGs, you think it's just need to be crossed before we finish? Because we got 7 minutes left.
Yeah, this is one important. Yeah, so might be
Yeah.
this is the
So you
last
pick up,
list.
yeah.
Yeah.
Thank you.
Just going quickly through this, 14-year-old boy have syncopal episode. He's an athlete. The episodes occurred while he's standing at home. He hasn't been feeling well. He has headaches, myalgia, arthralgia. He has got chest pain, but he's not sure whether it differs from the chest pain and the aches he have. With this history, are you worried or not worried?
No.
Not
I'm
worried.
not worried. Anyhow, you did
No.
an ECG. Okay, and you started to get worried when you've seen this ECG. Why? Because you've seen, look at V2. I'm gonna help you quickly. Look at V2, V3.
T-wave, yeah.
T-wave, yeah.
Yeah, look at V2, V3, V4 and V5.
And there is ST elevation also.
Excellent. Okay, so I pointed here. Just, I want to copy this in your brain, guys. The ST elevation this way. I think Dr. Abad has mentioned, can you see this is the G point? What is the J point? This is the junction between the QRS and the T. The G point is elevated, okay? And this elevation here is concave because this is concave, okay? What are you gonna do? So just for the time, this is normal variant in pediatric ECG, okay? Very, very common. We call this benign early repolarization. Again, look at this one. Can you see the ST elevation? The G point is elevated. Okay. Again, look at this ST elevation here. Can you look at T3 and AVF? Can you see how the ST elevation is different? This is convex ST elevation. Okay, guys, did you make the difference?
Yes.
Yeah, this is pathological, this is infarction or ischemia, and you got reciprocal changes, you got depressed ST elevation in other leads. I'm going to give you another one here. Again, this is a convex ST elevation accompanied by PR depression, and if it is diffuse, this is pericarditis. I'm just going fast because I'm just running out of time, I think, because we have so many questions.
No junction here, right?
Sorry?
No
What?
JH junction.
No, I'm going to show you the J junction again. Can you see that one? Where the arrow is pointing. So this is benign early repolarization. I'm going to tell you this is very common in children. We've got so many referrals of that. The history you have doesn't denote any cardiac abnormality, and this is normal. But if you have an ST elevation like this, you start to get worried. And with this one associated with PR depression, this is pericarditis, which also we're not worried. We just give ibuprofen and we might need to repeat the ECG in 4 weeks' time as well. I'm just putting everything together, you know. This is the ST elevation, which is worrying. This is a reciprocal ST segment depression. Okay. Yeah, keep calm. I'm just gonna mention on the first case why you have a large R waves on V2 to V5. This is very common also in children because you have a very thin chest wall. So you will have a very prominent R wave in V2 to V5, and the machine usually over-reported as left ventricular hypertrophy. Don't read the interpretation, okay? Again, left ventricular hypertrophy, right ventricular hypertrophy are anatomic conditions. It's very difficult to make the diagnosis on the ECG. I would trust an X-ray if there is cardiomegaly than an ECG, to be honest. Again, children chest is very thin. It can just over-report the electricity. Again, if you want to diagnose an LVH, look at only at V6, and usually there is stream pattern. There is ST segment, there is a P wave depression or inversion with V6. Okay, right ventricular hypertrophy is difficult in children. Sometimes the only clue is a bright T wave in V1. So I'm going a bit fast because of the time. Probably we have time for this last case about a 15-year-old girl. She collapsed in a party. She had alcohol. You just decided to do an ECG as a part of the workup. This is what you have. What do you think about this ECG? Is the history first worrying from a cardiac perspective, the history?
Drugs, alcohol, the environment is favor for drug injection, like
Yeah. Yeah, but you were worried, so you did an ECG. What do you think about this ECG?
It's abnormal.
It is abnormal, despite the history is not worrying. Can you see V6 here?
Yeah,
It is
T-wave is inverted.
very tall, and there is associated SD S wave as well. Look at V6 here. What is the T wave looks like?
Inverted T-wave.
Remember what did I tell you about T wave in V6?
Always abnormal if negative.
It shouldn't be negative at any age.
Yeah.
Yeah, so this is abnormal. Even if you don't have a prominent R wave in V6, if you have only inverted T wave in V6, you should get worried, you should speak to cardiologist. Okay. You think I don't have time for further cases? I'm gonna stop here. So I think because we have so many questions, I didn't manage to finish on time. However,
No,
I'm happy to.
1 minute on time, in fact. Fine.
Yeah, I still have few cases, you know, sorry. But that's fine. Yeah, if you have any questions regarding what we have discussed so far.
Can we have another session to complete the other cases in the future?
Yeah, we can arrange that definitely. Yeah. But hopefully you get the message. Don't look at the ECG separately, and you have to be careful of the benign variants on the pediatric ECG. When you look at an ECG, we all learned ECG in medical school, but from an adult perspective, not from a pediatric perspective. And this is the reason sometimes we get more adult-minded about the ECG. They get worried about some stuff that we're not worried about. We're very relaxed about so many things. On the other side, that's things that is normal on an adult ECG, we consider it as abnormal. Okay. Any questions?
Any questions, guys? Because we got
What was the diagnosis of the last case?
Sorry, which one?
diagnosis.
What? I didn't hear that. Say it again.
Alcoholic patient was a diagnosis of alcoholic patient.
Yeah, this is just coincidentally. She was lucky to have an ECG. This child, what do you think might have? Cardiomyopathy or hypertrophic cardiomyopathy or dilated cardiomyopathy. You've got a very dilated left ventricle with a strain pattern, inverted T wave in V5 and V6. Okay, she might have dilated cardiomyopathy. Okay, she was lucky to have an ECG. It has nothing to do with alcohol. Okay, and if you noted here, you've got diffuse T wave inversion in T in 1, 2, 3, AVF, and from V1 to V6. This is completely abnormal. Did you get it, guys?
Yeah, I think it's pretty clear after you explain everything.
Yeah.
Thank you very much for this amazing talk and for decoding the ECG today. Very brilliant talk. Thank you very much. We have some polls to put on, and I encourage you guys to participate in this. It would be anonymized, so no one would see what's your answer. So my colleague will put that on the chat. So we have the chance to press the button and see what you got from this. Come on, guys. We can't see any answers yet. Can anyone see the polls? Because we got technical issues with, yeah, it's not here. Yeah. Anyone can see the polls? Because I can't see the answers. No one's submitting answers yet.
Yeah, we submitted already, Ilham.
Perfect. Thank you. Good response. And just a quick reminder, so we need the feedback to improve what we are doing and for better performance. So just we are keen on your feedback, please. And you also receive your certificate upon filling this feedback, please. And thank you. So the poll ended. I couldn't see the results. Thank you very much, and we are very joyful with this presentation, and we are so delighted to have you today, Dr. Badawy and Dr. Hrfi. And it's really rich presentation. And as you know, many people struggle with ECGs. It's just like, oh, ECG, let's get back and have a praise. Hopefully, this session decodes the ECG for many of us, and you feel more comfortable with dealing with ECGs, as it's very, have you showed the poll's answers, Mohammed? It's getting back again. Abdul?
But it is not working, Ilham. It is not working. I'm not sure.
Yeah, because I haven't seen the answers or the percentage.
Yeah, I can't submit it. I just can see it. I can't submit it, Mohammed.
Oh, unfortunately. Abdul, are you here?
Don't worry, I think there is a technical issue. Don't worry.
Oh, okay, fine. Thank you for all people who submitted their answers, and unfortunately, we're not able to see all the responses, but we are really very happy that you joined this session. We got a very great audience today and a very big number, and we are so happy with our presenters, and thank you very much. Thank you. Any questions that not been answered yet would be answered through the email. And if you have any queries, just send it back to the academic office. We'll try to sort things out and we will send you. And just not to forget to fill your feedback and to have your certificate and to put that on your portfolio. I see them question.
How can we get the certificate?
After filling the feedback.
Just for everyone who's asking about the feedback, in the feedback form, there is the first line is to put your email. When you put your email and submit the feedback, we'll send the certificate to this email. So you need to fill the feedback to get the certificate. Otherwise, you will not get the certificate. You can have the feedback form through scanning of your QRS or just clicking the link that is provided. Thank you, everyone.
Thank you. Thank you. So we'll leave the QR code on the screen for those couldn't see the links, and we're happy to receive your feedback. And thank you for joining us today. Enjoy your time and enjoy your lunch. Thank you very much. See you in the upcoming sessions from BSAPCH.